Okay. Hi, good morning, everyone. For me, it's not a good morning because I'm just continuing from my night shift. So I hopefully won't be speaking a lot of stupid stuff with you. Okay. So on lungs and DVT, I was asked to bring the talk on like a bit of the basics, but I'm a clinician, so we're gonna go through why the hell would you wanna scan something that has air in it? Like, why do you think it's important to scan the lungs? Can you even see through the air? Yes? No. What do you rely on when you scan the lungs? You rely on artifacts, yeah. So with ultrasound, you can use it instead of your stethoscope or as an adjunct to your stethoscope because you can use it with no, let's say, bad things happening to your pediatric patients and both in adults. And it's really good when you have someone breathing like something like that. Like today at 2 a.m., I came in to an old lady, 85 years old. She was breathing just like that. And you just use the ultrasound and see what's going on in her lungs, okay? You have someone who's dyspnoid, because you can have someone who's dyspnoid who says what? For example, pneumothorax, pulmonary edema. You have someone who has asthma, pulmonary embolism. And you can use this probe to rule in someone or rule out someone, okay? So you have like a wide differential diagnosis. You can see the pleural effusions, you can see some pneumonias, you can see the pneumothorax, and we're gonna go through how you can actually see it, because it's not just like, yeah, there's no lung sliding, this is a pneumothorax. It doesn't work exactly like that. And always, as Elton John said, like, it's not just about the lungs. Don't go breaking my heart. It's like, don't go forgetting about my heart and also my IVC, okay? Because it's always a composure of all these things. As a clinician, you're not a pulmonologist, okay? You're not just gonna take a look at the lungs and say, yeah, okay, the lungs are okay. But is there something else that might be causing dyspnea to my patient? Is it like a full IVC and I see some thrombosis here? I might even visualize some thrombosis here in the pulmonary arteries. So like, always take a look at the whole context, okay? Your patients do not just have lungs, they have many organs, and you need to integrate everything into one, let's say, into one whole, okay? And of course, for the legs part, don't forget about the legs, because usually people walk on them. But it's really good for your dyspnoic patients as well, okay? You're gonna see how you can rule in or rule out someone who has a DVT and who can also bring from the DVT to the PE, okay? It's a it's a test with a high sensitivity. It's really good, really fast. You can do it really fast. And I'm also gonna talk about how you can do it. Okay, so for let's say the lungs, you have a really, really good thing, which is called the Blue protocol. This is something that we use in the ED department. I think before we knew about the protocol, we kind of used it intuitively, but like, meh, not really that much. But if you use the whole structure, it's really good and it's quite logical. I think this is something that maybe you can take a picture of, because it's good. It's going to be good for you afterwards when you're going to work in your clinical departments. So first of all, of course, you go there, you take a look at the lungs, and you see the lung slidings. If you don't see the lung slidings on both sides, your patient is not breathing, okay? Maybe you should go there and first start with like palpating the patient, like, hey, are you okay? Do you even have a pulse, okay? And then afterwards, after you establish this, you see someone and you see the lung sliding. So yes, I see the lung sliding on both sides, so present, okay? And then I'm gonna look at the lungs, and we're gonna go through how actually we're gonna do it afterwards, okay? I just want you to understand the concept first. So you see the sliding and you see the B lines. Do you know what the B lines are? Yeah, so it's like there is fluid in between the pleuras, okay? And you can have B lines even as a normal finding. So if you have like one B line, that's okay. If you have someone who has B lines here, 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 not that good, okay? Your lungs are wet and you are either fluid overloaded, or on the other hand, you can have a non-cardiogenic pulmonary edema, so kind of like an RDS, okay? So this is something like this, so kind of like a B-line profile. On the other side, if you have A-lines, so you have the normal artifacts, the reverberations, you take a look at the veins. And first of all, figure out if someone has a DVT. And then if someone has a DVT, they have a PE, correct? No. People can have a DVT, but no PE. So PE is likely. So it's more likely than it was before. And you have no DVT, then you take a look at the lungs, which we're going to do later with the abdominal views, because you can see the pneumonia, or if it's completely clear, you have a hyperinflated chest, then it could just be a COPD or something asthmatic, okay? On the other part, I'm going to go first here before this part, you have no lung sliding. And this is the thing that you have to understand about pneumothorax. Okay, so with lung sliding, you see the A lines. Okay, and then with this one, you see here, no lung sliding. Here, also no lung sliding. Here, you see lung sliding, but then you see something called a lung point, which means you have a no lung sliding and then lung sliding towards a certain part. And this is what? This is something that confirms a pneumothorax, okay? If you don't have that, then the pneumothorax is just likely. Because if you have a pneumothorax, for example, something that's this big, you can have lung points here, 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 here. And you can actually use the probe to circulate how big the pneumothorax is, okay? If you have a really monstrous pneumothorax, which means no lungs anywhere, you're not going to have a lung point, but you're still going to have a pneumothorax. Is that clear? Okay, perfect. And the C lines, it's like no really C lines, it's just like pneumonia. And I'm going to show you some pathological findings later on. So this is on the lungs protocol. If you take a look at the C lines, again, you can see here. So let's say one, something like that, normal. If you have some of them, it's not normal, but then it depends on where it is, okay? And then when it comes like this, when you have like a shower of comets, you can have it from here till here, and you're gonna have a pulmonary edema. And afterwards, we said A lines, so no lung sliding, and with the lung point, and the C line, which is the pneumonia, so the consolidations here, and I'm gonna show you the clinical cases later on as well. And also, when you're going to take a look at the first time, okay, you're going to see like some B lines. And then after a few years, you're going to start to figure out that these B lines actually mean also the severity of the sickness, of the illness, okay? So the more B lines you have, and then you have like different B lines as well. For example, during COVID times, this was a really good screening tool when you could actually see, okay, this one they're probably not going to make it without the intubation, okay? So you could see B lines, severe B lines from here till here, different radiuses of B lines as well. And it's really good to kind of see something like that. Quite okay, something like that. More shitty, something like that, very shitty, okay? And then after that, how do you actually scan the lungs? This, perfect. If you have 1 hour to be with a patient, do it. I never have 1 hour to spend with a patient. This is an adjunct. This is the full lung ultrasound. So do it here, 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 on the sides, on both sides as well. Good when you have time. If it's 7 a.m. in the morning, the only patient that you have, go for it, okay? But usually it's not, and we're gonna show you later how you can actually do it. So it's clear, you can use, let's say, the most parts that you want to see and actually get some useful info from it. And then afterwards, again, for me, what's the most important? This part for the pneumothorax, this part for the fluid because it goes down, okay? And maybe sometimes if I don't see these lines, I go to the back as well. especially in the older patients. Okay, so about the legs. When you scan the legs, do you order a D-dimer? This is something that I put on last year, and I'm going to advocate for that. Please, when you want to order a D-dimer, have a reasoning behind it. A D-dimer is such a non-specific test that you really have to know what you're doing with it, okay? So you have like a really good clinical, let's say, decision tool. So it says, you do the Wells score. You already know the Wells score from the faculty, correct? Okay, so if someone has a really low probability, you can decide on the D-dimer. And if the D-dimer is negative, no DVT, also no ultrasound needed, okay? But of course, someone that's gonna come in and have a leg like that, kind of more probable, were operated 2 days ago, stinks like a DVT, okay? And this one is gonna have like a high Wells score. So we're gonna say, yeah, DVT likely. We're gonna do the ultrasound. Do you see any D-dimer here before that? No, because there's no D-dimer here, okay? You see, this is a sore point for me, the D-dimer. And then afterwards, you see whether you have a proximal DVT or maybe a distal DVT. But for us, what's the most important part, and we always scan this part and this part, because 95% of deep vein thrombosis are found here. If you don't find it, sometimes you maybe didn't scan hard enough, but sometimes they can be hidden inside the structures as well. All of your patients are not going to be models with like perfect legs. Usually the legs are like meh, this big, and then like there is no penetrance as well, so you cannot be really sure on what you're seeing. A really important thing that I want you to distinguish: you're not doing this, okay? You're not doing the whole leg ultrasound. It's either a 2-point or a 3-point. Basically, what's the only difference is, besides the common femoral vein, you do the femoral vein that goes a bit down until you can see it. That's the only difference between two, and I think this one doesn't loses you that much time, so you can't do it. So I usually do stuff like that, and I'm gonna show you the difference on doing the ultrasound with someone laying down on or standing up. And now we're gonna do it, okay? Perfect. Any of the models here? Okay, run. Perfect. Okay, you have someone who is quite dyspnoic. Usually they're not coming in like that, okay? When they're this dyspnoic. So first of all, when I have someone like that, I always like to start in the subcostal view and just to take a look at the heart and the IVC. And then afterwards, I move to the lungs. Okay? So can we maybe switch to the, ultrasound thingy? Perfect. Okay, so we're gonna use the cardiac probe. We're gonna strip the patient and then put the cardiac probe here. Okay, what do we see? So let me see if I can draw. Okay, on this part, the liver. Okay, let me see, liver. This, the heart, yeah, okay. And then can you just, let me just do this. Give me a second, erase, yep. Okay, can you go from this part to the IVC a bit? Yeah. So if you cannot see the IVC, usually you just move the hand, go above the line. Can I just use my arm? So my window, it's usually like this. So it's on this side, you have the liver, and then the right heart and the left heart. And from here, you just move a bit here, and you see the IVC, nicely hydrated, okay? If it's someone that's dyspnoic and has a IVC that's this full, you're not gonna help them with giving them fluids, A. B, pulmonary embolism more likely. Yeah, we're clear on that? Perfect. And from here, we've seen the function. Can you just move to this one a bit more? Yeah, the function of the heart, So give me a second. Function of the heart, what are we going to say? Good, bad, or meh? Can I hear the good? Okay, meh, bad, perfect. Okay, so it's good, okay? And for me, this is like really, really important, okay? Because I see, okay, I have time. I don't have tamponade. I have time to scan the lungs. And then I either use the same probe and go on these two sides, or can you go to with the same probe?
Yeah.
Go to this side. Perfect. Okay. Okay, can you just turn it around so you have the opposite part? I'm gonna come here. Okay. Okay, so what do I see here? Well, let me see. What's this? The diaphragm? What's this? Liver, yeah. If we are on the right side, it's usually the liver, yeah. And then here, the kidney, and here, this part, the lung. Can I actually see the lung? No. So what's important for me is I actually can see it. Let me see. If I have a severe pneumonia, which I'm going to show you later on, yep, like this. Can you just scan it a bit upwards? So we have the diaphragm. Okay, here. When you see the diaphragm like this, and the liver like this, and almost the same image on this side, this is good. You don't see the lungs here. This is the artifact of mirroring, okay? And if you see this, there is no effusion in the chest cavity, okay? So this is a good sign. And then if you go on the other side, you do the same thing. Okay, so again, diaphragm, this, yeah, so the other liver, so the spleen, and kidney, and again, let me just see if I can see, can you see this? Yeah, so again, normal mirroring artifact. And if you use the abdominal ultrasound, and I usually use, when I see this, I say, yeah, okay, I'm quite happy. I don't have an effusion. I use the abdominal ultrasound because it's the abdominal probe, because it's a bit clearer and I can go a bit deeper inside the lungs. On the right side, yeah. Here, where you can just scan and I'm just gonna draw. So here you see the liver coming up, and here you're gonna see the lungs coming down, okay? And when you're going to scan the lungs, give me a second. When you're going to see the lungs here, you can see the sliding of the normal sliding of the lungs. So you don't actually see the sliding, but you see the, let's say, the effect of two pleuras going together. It's like ants walking. I don't know what kind of descriptions they have as well. Okay? And here I see no B lines, so I don't see stuff like that. So it's something that needs to start here and go towards the end of my screen. And if I would see some, you see the small B line here? There is one B line here. Is he sick? No, it's a normal finding, okay? And can you go again with now with the linear probe? Just so I stay on time and show you some pathological findings as well. And then you go with the linear probe and just see whether you have sliding or not. Okay, so a bit more depth maybe, because you're not going to be able to see. Yeah, okay. Give me a second. Okay, perfect. What's this? Rib. What's this? What's this? The pleura. So rib, rib. I feel like a frog. So rib, rib, pleura. And then you have the soft tissue here. You have some veins and arteries here, because this is the upper part. And then you see the normal A profile going down. Yeah? If you see this here, and on the other side, here and here, you can say no pneumothorax or no large pneumothorax. You can have like a smaller pneumothorax with someone who has a spontaneous pneumothorax, but you're usually not gonna look for that. And then I wanna show you the legs part as well. Let me unfreeze the image. If you take a look at the DVT, the test is simple. Show your picture, push it down, yeah? And now if you're gonna go here, let me see if I see some veins. Maybe a bit more medial. Okay, can I help you? Yes. Perfect. Okay, just give me this. You see, here. See, can you give me some gel, some gel?
Yes.
Perfect. Let's see. Okay, you see what I want to see now? Yeah? Which one is the, can you just hold this here? And you can use a bit less. Which one is the artery, which one is the vein? What's this? How do you know it's the artery? Because it's saying hi to you, okay? It's pulsating. What's this? Why is it also pulsating? Because it's coming from the artery, okay? And it's not actually pulsating. You see, because it looks like it's pulsating, it's not. Can you press it down? Okay, and you see, this is the vein, and you need to press it down completely. Okay, can you press it down again? This part, I'm still not buying that. Press it more. More. Perfect. Okay, that's good, okay? If you have a compression like that, you can say, on this part, I do not have a deep vein thrombosis. And then you go from this part, and this is what you're gonna practice later on. You go up, 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 up. Okay, this is the superficial vein, and then you need to go down now, down, 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 and then like every centimeter, go down, press, go down, press, go down, press, go down, press. It's quite shitty to see, right? Can you stand up a bit? Can you stand up? If it's possible, always have your patients standing up. Most of them can stand up. And now look at the same vein. We're going to take a look at the same vein that we've seen before. Do you see it? Here, a bit more. The same vein. Do you see how much bigger it is? Yeah? Is this better than before? And it's completely logical because you have someone standing like that, you have the stasis going down, and you have the same vein, which is much better. If possible, I would like to do the central lines like that as well, but people don't tolerate it as much, okay? But if you do it like that, then also when you press it, can you press it? More, 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 more. Yeah, almost, okay? And always I use the other hand to just like press it against my hand, okay? And you go here, and on the other side, on the knee part, can you just go on the knee part so we see the popliteal lines as well? Okay, you see the popliteal vein? How many popliteal veins do we have? First one, and then it goes into 3, okay? And then you go down just towards they go to the trifurcation, and you also press it down until you are able to see them. You're not going to be able to visualize the distant part, but you don't really care about that, okay? Perfect, okay, thank you very much to both of you. And now I want to show you, you have like 5-ish minutes? 5? Perfect, okay. I want to go back to the presentation. Yeah, perfect. And I want to show you, because usually people that come in as models don't have pathological findings, which is good, okay? But I want to show you a couple of pathological findings so you'll be able to see, okay, what I see on my colleagues, this is okay, but if I see this on the patient, it's not okay. So for example, just like one of the cases, this is our rhesus bay, and it's someone that had progressive dyspnea, COPD, blah, 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 quite a shitty heart. And then you take a look at the patient, you kind of like say, yeah, kind of breathing really fast, Like the blood pressure is like meh, kind of tachycardic. And then you see the ECG monitor, you see the ECG. I don't really like what I see, but it's not a STEMI, so it's quite okay for now. And then you take a look at the differential diagnosis. Very white, correct? And then you take a look at the lungs of this patient, the heart and the legs, yeah? And on the first part, you see the lungs. What's this? Normal A profile, okay? The same as we've seen in our colleague. On this part, nothing really special, correct? We see the lung sliding, coming down, maybe some like 1 or 2 B lines, but that's it. The heart? Do you like the heart from this direction? Is it, okay, is it good? Is it meh? Meh, yeah? I would also say meh, okay? But what I don't like here is this part coming down into my heart. The right ventricle, when you see it, it's usually small, okay? From this angle. This one kind of like doesn't want to be small, kind of wants to push back, okay? And if I use the other, the 4-chamber view, is this okay? Or is like, nah, not really okay? I mean, the heart is pumping fine, correct? The function is good. The left ventricle is pumping good. But the right ventricle, fucking huge, yeah? And it's going inside the left ventricle as well. What is this? And those of you who said pulmonary embolism, wrong. It's a strain of the right heart. It could be pulmonary embolism. And of course, when you take a look at this, yeah, for sure. And when you take a look at the IVC, quite full, quite juicy as well. You take a look at the legs. You see this, not compressible, PE more probable. And then you, of course, do the CT. And on the CT, you see this. Let me just show you this. What's this? This is then a pulmonary embolism, okay? Because if you don't visualize the thrombus, it's not a pulmonary embolism, but you just see let's say, the effects of the pulmonary embolus. And then a few more cases. So one dyspnoic patient, quite tachycardic, quite shitty saturation rate. So we see this. Do we like what we see? Yes, no. Is this not? This is the lung, yeah? What's this? Kind of like a few B lines. And then you take a look at the lower part here. Can we maybe turn off the lights? It could be a bit maybe better seen for you. Okay. Let me go a bit backwards so I'll be able to see it. What's this? Why is it black? That's fluid, correct. What's this? That's a collapsed lung. Yeah, perfect. So this is a pleural effusion. Yeah? And then you see the heart. Is the heart doing good or not that good? Not that good. Quite shitty, I would say. Yeah? So with the heart like that, pleural effusion, B lines, what are we looking at? And we have B lines here, 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 here. We're looking at pulmonary edema. Yeah? Okay. And then here you can also see like quite shitty palpations of the heart. Another case I want to show you. So we said someone who has sharp pain on the right hemithorax, trouble breathing, again, shitty saturation, a bit tachycardic like they all are, a bit hypotensive like they all are. And you take a look at the left lung. Is this okay or not okay? This is okay, yeah? You see rib, normal sliding. I take a look at the left side, I use the M mode, and I see the normal, what's that, the sandy shore, something like that, yeah? Yeah, the seashore, yeah? So you have like the normal grainy sign here. I don't use the M mode, I'm more trained to just take a look at the pleural signs, but it's quite nice if you're like not really sure, it's good to see it. On the right side, I see this. What's that? It is an A profile. Do we agree? Yeah, it is an A profile. But it's like the shitty part of the A profile, okay? So it's nothing is really moving, so you don't see any movings. Is it a pneumothorax from this? Can you say it's a pneumothorax? Because we learned it's not. And this is the lung sliding, or the lung point that I want to show you. Here you have the normal lung sliding. Here you have the pneumothorax, and this is the lung point. Yeah? If you see this, pneumothorax, check. Okay? You can have this in cases when someone has a pleurodesis, for example. Or if you have someone that's intubated on just, when I intubate someone and I go like a bit too deep to the right side, on the left side I will also see this. So no moving whatsoever. And I think, yeah, again, the M mode, if you want to see it, the barcode sign, yeah? So you can actually see if this is a pneumothorax as well. So with this, you can see like the blue protocol is quite useful. If you look at my chain of thought and how it goes and how do you use it, it's quite good. The last case that I want to show you, I think it's maybe this one. It's just like to see. Do you know what is this? It's an image that makes your sphincter go, yeah, okay? Because you have quite a lot of pericardial effusion, yeah? And it's pressing down to the right side. The lungs are okay, but this person had troubles breathing, yeah? So you have a tamponade, a clinical tamponade here. And the last case is, or maybe the last two cases, just to see this one. What do you see here? This is the C line before that I was telling you about. Normal diaphragm, then some fluid here, but here you have the consolidations. So the air bronchogram, and this is a sign of pneumonia. 2 shifts ago, I had a patient coming in, really trouble breathing, 40 degrees Celsius, and something like this that looked like the liver from here to here. A really, really bad pneumonia, intubated in 3 hours from the presentation of the clinical signs. Something like, yeah, this is the one, so you can see it. And then the last one, we had someone who was admitted to the hospital, again, similar vital signs as the ones before, and I want to show you just so you can see it. So on the right side, when you do the compressions, is that okay or no? Yes, okay? But it's okay on this part. You need to do the whole leg. And when you do the whole leg, on the right side, all good, yeah? You see, you do it, and then when you press it, it winks at you. That's all good. On the left side, it's like that. You take a look at this. Do you know what I'm actually pressing? Do you see that it's winking at me? This is the artery that I'm pressing. This on the other side is the This is the thrombus. Let me show you again. So artery, and this is the thrombus inside. You can actually see it. It's quite rare to see it. Usually you just cannot press it normally. This was one of the cases, and she also had a pulmonary embolism. So with this, I want to thank you for your attention. This is where I work at, where we do our juju magic. This is our team. If you ever feel like coming, do come. I mean, Slovenian, it's not that difficult. And if you want to stay in touch, this is my Twitter. And thank you for your attention. That's it.
Thank you so much for your exciting lecture. Are there any questions from the audience or online? Any questions? Feel free. Okay, I have a question for you. Mm-hmm. If you find A lines, mm-hmm. how long do you take, or how much time do you take to find the lung point?
Quite a long time. I mean, I really need to see, if it's someone that has like a blood pressure of 60-30, saturation of 60%, Then if I have like the A lines, I will just go, like, can I just use you? I will just go here, 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 here. Okay, no A lines, no A lines, no A lines, no A lines. Okay, looks maybe like a tension pneumothorax. I'm not gonna fool around. I will just, okay, and decompress it. And then see, okay, if it's air coming out, that's okay. Then I'm just gonna do the chest drain. But otherwise, if it's someone that has like a 92% saturation, kind of stable, then I will take my time. It depends on the clinical context. And if it's possible, for sure, I will try to just confirm it with the lung point. Yeah?
Yes, thank you.
Yep.
Another question? Okay, then thank you so much. It's always so good to have you.
Yeah. Thank you for the invitation.